All right, everyone. So, welcome back to our CCS exam prep course. And over the last 2 weeks, we've been talking about the different domains of the CCS exam. We haven't done our official domain review. That is because we discovered that many of you use the encoder at work, and I want to ensure that you know how to use the coding manual, but also that you recognize, understand, and can apply the coding guidelines because those are the skills that you're going to need to be able to, well, one of many skills that you're going to need to navigate the CCS exam. So, as promised, starting today, and it's February 10th, 2025, we are going to be working through scenarios that will that have a goal of getting you to be able to apply the chapter specific coding guidelines. And for this first day of this journey with these chapter specific guidelines, I'm going to add in a slight little twist. And I thought that this slight twist was important because of the fact of the scenarios and the end result. So I'm going to get going. And as usual, we will be doing some audience participation. I think I will, for now, allow you all to kind of drive your process individually at your workstation before I start to call on you. As a reminder, I do take attendance actually a couple of times throughout our 3 hour time frame together. And that is basically because I want to make sure that you're here when we start, you're here in the middle, and that you're here in the end because you are fortunate enough to have this course and the subsequent materials covered for you. And so I like to make sure, from an accountability perspective, that you are definitely all in. All right, so let's get started with kind of the twist I am adding to our discussion tonight. So far, you all have been reading section 1A and B of the coding guidelines, and then you started reading section 1C of the coding guidelines, which are the chapter specific guidelines. And so, as I was doing my preparation for your experience tonight, I said, I think we need to add in one more component, and that is section 2 and 3 of the guidelines. And I know some of you are going to say, well, wait, I haven't read that yet. You haven't read them this go round, but you read them at some point in your training. Or for those of you who are working as inpatient coders, you probably see these guidelines carried out inside of 3M. But I want to remind you that on the day of the CCS exam, you won't have 3M. So when we go through our scenarios today, um, I want us to be intentional about you being able to effectively use your coding manual, and hopefully by Wednesday or maybe by next week, you will have received your manuals that you hold in your hand, the ones that you actually are going to take with you on to the CCS exam. But for now, many of you are using the electronic code manual. And so I want to be intentional by ensuring that every scenario that we attack, that before you even look up the codes, that we talk a little bit about the the guidelines and some sequencing, and then actually look up the codes. As a reminder, on the day of your CCS exam, that exam is multiple choice, but knowing the guidelines will save you a lot of frustration and time because you won't be tricked when the same codes are presented in more than one answer choice. They're just presented in a different order, and you won't be tricked by um, the order. I also will call out that on the CCS exam, you have a scenario and they ask you, what is the principal diagnosis? They're expecting you to apply guidelines and know what that code is that would go first. But there could be questions on the exam where you're asked to identify the secondary diagnoses. And so today, and for the next couple of sessions, for every scenario that we look at, you will be um, asked to identify that principal diagnosis first, followed by the secondary diagnoses. And as it relates to the secondary diagnoses, when you see the answers displayed on the screen, I pretty much have them in no specific order unless there is a coding rule that calls out specific sequencing. But for the most part, my objective for you tonight is that A, you can use that manual. And many of you saw last week that you definitely are encoder dependent. And so, it's not a bad thing. It's just your reality, right? And we want to get you to a place where you go to that exam and you're using those manuals with ease. All right. So, we're going to attack excuse me, attack. I think my throat is like scratchy from Super Bowl yesterday. So we're going to attack this journey, as I've mentioned before, um, by chapter, right? So I asked you all to read the chapter specific guidelines. Many of you last week had indicated that you already got started. Many of you indicated that you were going to get started. And nonetheless, if you haven't gotten started, you're gonna you're gonna feel overwhelmed by trying to use the physical manual. Okay, now here's the guidelines. So I don't want this journey for you to be overwhelming. I want you to proceed from week to week with some confidence and give yourself some grace. But you got to put in the work if you want to get that end result. So I will be displaying the first scenario on the screen. I will go through the scenario and then have a conversation with you about the guidelines that are appearing in a particular scenario. And then I will put our trusty timer up to allow you an opportunity to locate the appropriate codes. All right, so our first scenario, we have a 34-year-old male who is admitted to rule out AIDS. So let me just pause for a second. And as I am calling out the guidelines, hopefully you have a hard copy of the guidelines as we discussed, because you may want to go over to a guideline that I call out and, make some notes or whatever for yourself. So I'm stopping at this first sentence for a reason, because I have found that in medical record documentation, The word admitted is sometimes confusing because you're like, were they admitted to inpatient? Were they admitted to observation? Were they admitted to outpatient surgery? And so, what I would like for you to know for all of these scenarios that we're going to be doing, and just to give you, I don't know, something to look forward to, I only have 3 scenarios per chapter specific area. And I do want to call out that I do have scenarios for those areas that don't have official coding guidelines, just because I want to make sure that our end result is that we go through all 22 chapters. So I want to let you know all of these scenarios that we're going to be coding at this point are going to be the patient was admitted, full inpatient admission. So, given that, I'm going to continue and I'm going to come back to this first sentence to call out a guideline that you may or may not know exists. So, the onset of the patient's current symptoms were approximately 2 months ago when the patient began experiencing a fever with shaking, chills, night sweats, anorexia. Social history is remarkable for IV heroin use, drug use. There is no history of homosexual activity. A physical exam reviewed diffuse lymphadenopathy. And after study, the physician documented the final diagnoses. And let me just pause for a second and call out something you should know. The order in which physicians or providers list the diagnoses does not necessarily dictate sequencing order because physicians don't go to school for medical coding and henceforth would not necessarily know to put the principal first. So, you, as the coding specialist, the future CCS, I like to speak things into existence, you are the one that would say, okay, according to guidelines, this is how I would execute. So the final diagnoses are acute immunodeficiency syndrome, pneumocystic carinii pneumonia, CKD, chronic kidney disease, stage 2, and heroin abuse. So, so many juicy guidelines, so many juicy guidelines in this one scenario. So, as I read the first sentence, the first guideline that comes to mind for me is the fact that I see the word rule out. And according to section 2 of your ICD-10-CM guidelines, in the inpatient setting, you can code rule out diagnoses as though they exist. But then you get to the word AIDS, and there's another guideline that trumps that guideline that basically says you can only code confirmed cases of AIDS. Okay, so as I continue through the scenario, I start to see all of these signs and symptoms. And so the next guideline that comes to mind for me is signs and symptoms that are integral to a disease process are not coded separately. And then I say, okay, let me keep that in the back of my mind. So then I continue to read the scenario. I see that my patient does have a history of IV heroin drug use. I also see that the physical exam reveals diffuse lymphadenopathy. And so One thing that I would just really um, admonish you to do is if you see something that you don't know what it means, you should take a look at it to really understand that condition, right? So, lymphadenopathy, the suffix pathy is disease, lymph nodes, um, adrenal gland, right? So, that means that the patient has enlarged lymph nodes. And so, one of the questions that I would be asking myself is, is this tied to a condition? And then also, as I continue to look at the scenario, what is the physician saying that's going on with the patient? And so, um, the final diagnoses don't always um, call out all the diagnoses that we should be coding, because sometimes you see in the note they actually say the patient has XYZ condition. They treat XYZ condition during the hospital stay, and therefore, it meets the criteria for a secondary diagnosis. How do I know? According to section 3 of the ICD-10-CM diagnoses, other diagnoses are those diagnoses that require, and I'm summarizing because I don't have the guidelines in front of me. And in case you all are wondering, I do have my contacts on today with my reading glasses. Well, I don't have my reading glasses on right now because my screen is big, but I don't have my coding manual open. So I am summarizing what's in the guidelines. And so for a secondary diagnosis, the guidelines talk about conditions that meet the definition of secondary diagnoses are those that increase the length of stay, require diagnostic treatment, some other stuff, right? There's those bullets that are in section 3 of the guidelines. Okay. So after I said all of that, how many of you are in your mind like, whoa, 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 and whoa? I would not have thought through all of that in that manner. And right now, I have the audio turned off for a while because I want you to be able to A, focus on me, and really just be in a space where you are thinking to yourself outside of me. Because sometimes too many voices can get confusing. So, initial reactions to what I was saying as I was looking through that scenario. And I got some more to say, but I wanted to pause for a second. And you can go ahead and um, type your thoughts in the chat. And I know the chat is working because Rhonda was laughing at me talking about my voice, a little scratchy after the Super Bowl yesterday, because I love me some football. And although the Chicago Bears, once again, did not make it to the Super Bowl, I personally was rooting for the Philadelphia Eagles to win. I actually predicted they would win, and I wish I would have bet some money or something. Maybe I could have retired. Not likely. So I will just do another intentional pause to allow you all to gather your thoughts. All right. So, given that you guys don't have any thoughts at this time, I will just share some additional thoughts that come to mind when I read this scenario. So, I see that my patient has AIDS, and I see my patient has pneumocystis carinii pneumonia. And so, there's a couple of more things that come to mind for me. So, number one, according to the guidelines, if a patient is admitted for an HIV/AIDS related condition, the principal diagnoses should be, AIDS, followed by the diagnoses for all of the, I think they call them HIV related conditions. I call them manifestations of the AIDS. And so that right there gives me a clue uh, from a sequencing perspective for this scenario, because it is clear to me that the fever, the shaking, the chills, the night sweats, right? That is characteristic of just plain old pneumonia. And so that comes to mind. And the other thing that comes to mind for me as I'm thinking about when you all will have your coding manuals is that in, and while you're coding this scenario, I'm going to open my manual. But a lot of times in the coding manual, there is a symbol that tells you that XYZ condition is an HIV related condition, is a manifestation of HIV. So I happen to know that pneumocystis carinii pneumonia is an HIV related condition. All right. So I have gone through a lot of information, and what I am going to do is to give you all and one second, because I am going to put up our trusty little um what do you call this, timer. And I think that you probably need about, I would say, 7 minutes to code this scenario. So that is how much time I'm going to give you. If I can get this little timer here right. You guys know last week I was excited about knowing how to use this timer in Canva. And so I'm going to stop talking at this point and give you an opportunity to assign the codes for this scenario. All right, everybody. So that was 7 minutes. Do you need an extra minute or so? Okay, I will give you a few more minutes. All right, everybody. I want to go ahead and move forward. So, again, for right now, um, I won't be calling on you to give the codes because I want to allow you to just sit in your space and think. So, I will allow you to post questions after I reveal the big reveal. All right, so for this case, I have B20 for the AIDS, B59 for the pneumocystis carinii, stage 2 CKD, N18.2, and for the heroin abuse, F1110. In case you are wondering, I did not assign a code for the lymphadenopathy because it is commonly associated with HIV/AIDS. It's considered to be integral to the disease process. And so I would not code it separately. If I were looking at a record and the physician um, clearly states that it is not related, um, then I would code it separately. But other than that, I would not code it. So I'm going to pause for a second to see if there are any questions. And while I'm thinking about it, did you all hear anything else about your manuals? Oh, I see a yes. Wait a minute. Did I see a yes in the chat? Oh, nope. I see a nope, nope, nope. Okay. Nope, nope, nope. Okay. So we're still using the electronic manuals. Okay. I just wanted to know where we stood. All right. So as usual, I do want to incorporate breaks. Um, but I also, let me just tell you, we cannot move at a snail's pace because we only have 16 weeks together minus, you got the holidays and stuff that are not counted in our time. But I do want to give you a break because I know that you probably need time to go to the bathroom. I need time to go to the bathroom. So let's go ahead and take a 10-minute break. I'm going to put the timer on again so that you can take some time to relax for a second. All right. So that break time goes very quickly. And before we took a break, I was supposed to ask you, I don't think I did. Did anyone want to code something other than what was here? Did you have any difficulties? Do you see why the guidelines are important? And again, okay, someone said, I see why the guidelines are so important. Give yourself some grace as you go through this process because you're not going to learn them overnight. But it is my desire that once you get to the point where you're going through multiple choice scenarios, that you've built so much awareness of them because you've been reading them, you've been seeing them in scenarios. My desire for you is that you're like, yeah, this is why I need to learn them, and I am learning them. All right, let's keep going, because like I said, I don't want us to run out of time. And let me just reiterate. Usually, when I teach and I don't do a lot of these CCS exam reviews anymore, I do not do a review of guidelines. I do not do like these little scenarios, but I am doing them just to make sure we get everybody to the same or close to the same page before we get into actual records. All right, so the next case, the discharge diagnosis is urosepsis due to streptococcus. On admission, the patient's white blood cell count was 15,000. Urine culture and blood cultures were positive for streptococcus. After querying the physician regarding the meaning of urosepsis, an addendum was added to the patient's medical record. And so basically, they wound up with streptococcal B sepsis and urinary tract infection, also due to streptococcus B. So, um, a couple of things here. So, number one, the term urosepsis is a non-specific term in ICD-10-CM per guidelines, and we should query when um, that is notated, and that was reflected in the scenario. The other thing that I would like to call out is we see that there's an organism, which is the streptococcus. We also start to see some findings. White blood cell count was 15,000. They did do cultures of the urine and the blood. They were positive for that organism. And let me just pause for a second because I know many of you work at organizations where you don't have to query, but the query process is part of the CCS exam. And so the question is, how do we get you to a place that you see a scenario and you understand what is transpiring enough to know to make a query? So I guess there's a couple of things, and I want to use a personal experience to illustrate what the expectation is that you know. So I recently had a situation where a friend that is close to me was exhibiting some respiratory symptoms. And so she has an iPhone, I have an iPhone. I FaceTime with her. She looked horrible. I started asking her all of these questions. Really recommended that she go to the ER. I'm no physician, right? But when you're a coder for a long time, you know some things. So nonetheless, she proceeded to get on an airplane and um, went out of town, and got off that plane and was miserable. There was a couple of things I was concerned with related to her flying. Number one, pulmonary embolism. Number two, just being in the air with all that funky air that's going around. As a person who suffers from asthma, there's just some things that I'm not going to put my lungs under that in that situation. Nonetheless, um, went to the ER, admitted, double pneumonia, sepsis, and I um, was asking her questions as she was going through the process. Like, did they get a sputum culture? Did they get, blood cultures? What kind of antibiotics are you on? Just this whole gamut of questions. And I bring this up because if you look on AHIMA's website related to the CCS exam, one of the things that they talk about as a qualification for the exam is, and they say it's recommended. But if you look at this scenario, and you'll see where I'm going in a minute, they talk about, from an eligibility perspective, complete courses in the following topics: anatomy and physiology, pathophysiology, pharmacology, medical terminology, right? And we talked about this the last couple of weeks, that this was a skill that you needed to have. And I have been thinking about how I will deliver some type of mini review of some of these topics for you. I have some thoughts, and I will continue gathering them, um, and will present them at some point. But in order to query, you have to understand what you're reading from the perspective of when you know that there is a need to query. So this one was easy because urosepsis is in the guidelines as something that is non-specific and you need to query for. But the other thing that should be evident in this case, and again, give yourself some grace because you don't know what you don't know until you don't know it. The fact that the patient's white blood cell count was 15,000, that is also um, um, what's the word I want to use? It's a clue that the patient body is fighting, because a normal white blood cell count is like, I think, 4,000 to 11,000. So at 15,000, the patient's body has sensed that there was some foreign stuff going on in there. And it was like, whoa, whoa, whoa. Let's send the white blood cells to fight. So those are just some thoughts that came to mind for me. The other thing that I will call out is, you see streptococcal B mentioned twice, and one may think, oh, I'm going to need to um, code that um, how do I want to say? Is there a combination code? How am I going to handle it? Do I use the same diagnosis code twice? And general coding guidelines, I think, says that each unique ICD-10-CM code can only be reported once per encounter. Okay, so those are the things that came to mind to me as I was reading this scenario. Did anyone have anything else that you were thinking about as you read the scenario? And so, okay, no one has any thoughts. I did have one more thing that I was going to say, and I have forgotten. Oh, you talked about that you don't have your manuals yet, and I do know that the school likes to make sure that who is here is pretty much staying, because as I mentioned, you guys are getting a lot of resources for this review, and I don't think that they want to spend money and buy things if you're not here. Okay. Oh, now I know what I wanted to say. The last thing I wanted to say was that there is a coding guideline um, for sepsis. And let me just say this. Today, I'm giving the guidelines. Wednesday, I will call upon you to give the guidelines. So, and I will call upon you one at a time. And so I am just setting the stage today for those who haven't read the guidelines, and, just to get yourself ready. So there is a guideline, and I'm paraphrasing, right? There's a guideline that says if the admission is for sepsis or severe sepsis with a localized infection, that you should code um, the infection first, and then a code, for the localized infection. And in this particular case, we do know that the patient has this streptococcal B sepsis, and then they have the urinary tract infection, and the localized infection would be the urinary tract infection, right? And then the urinary tract infection was also due to streptococcus B. So once you start to look up these codes, you should see that there is a combination code that gives you the sepsis and the streptococcal B. Then you can grab the code for the UTI and an infectious agent code for the organism. So I think that's all that I want to cover. I'm going to give you time to look up these codes. All right, so I will reveal the codes. So first up, we have A40.1, which is that code that says, now I forgot what the scenario said. The streptococcus sepsis. Then you have N39.0, which it which is our code for the urinary tract infection. And then B95.1 for the streptococcus to go with the UTI. So I want to pause just to see if there is a question. And while you're thinking, is there a question? I did want to call out from a scheduling perspective as it relates to these scenarios from a chapter specific perspective. I am only allocating 4 sessions for these. So we're doing them today, which is the 10th. We'll do some more on the 12th. There is a holiday on the 17th, so we will not be meeting together. So we'll continue on the 19th. And my expectation by the 19th is that we've made some serious traction on these cases, because I will allocate a little time on the 24th, but I want to, at that point, transition over to ICD-10 PCS. So I don't see any questions in the chat, so we're going to keep on rolling. Last scenario for chapter 1 of the chapter specific guidelines. So this patient is admitted with pneumonia, also has multiple bilateral lesions of the vulva and vagina with fluid filled blisters. This history includes fever and pain for 2 days. Sputum cultures show group A streptococcus. History also includes pain, particularly with urination and itching of the genitals. The physician documents group A streptococcus, pneumonia, and vulvovaginitis due to herpes. So the principal diagnoses, there are some rules for that, but the reason for this admission is pneumonia, and I want to just plant this concept today, and we will talk about it as a later date. The admitting diagnoses is not necessarily the principal diagnoses. The admitting diagnoses could be different. I'll just plant that there, and we will definitely come back to it. So the physician documents group A streptococcus pneumonia and vulvovaginitis due to herpes. I feel like this is a pretty straightforward case, so I'm going to stop talking and give you time to code it. All right, so for scenario number 3, here are the codes. So the pneumonia, the J154, and then for the vulvovaginitis due to herpes, A60.01. Any questions on this scenario before we move forward? Bacterial strep. Let me go back. So the J15.4 is a combo code that says pneumonia with streptococcus. Okay. All right. Oh, so now we're on to neoplasms. I think the neoplasms can be pretty challenging from a guideline perspective, but some of them are also pretty straightforward. So let's get started. So our first case is we have a female patient with terminal carcinoma of the upper outer quadrant of the right breast with metastasis to the liver and brain and was admitted with dehydration. The patient was rehydrated with IVs and then discharged with no treatment given for the cancer. So there is a coding guideline. And again, I'm paraphrasing. You guys probably have the guidelines in front of you. And it just occurred to me I need to open my manual to look for the symbol for HIV manifestations in the tabular list. But there's a guideline that says when the patient is admitted for management of dehydration due to the malignancy, and if only the dehydration is being treated, the dehydration is going to go first, sequenced by a code for the malignancy. And in this particular case, that was the case. There was no treatment for the cancer, but we still are going to code it. And our patient had cancer of the right breast, which then metastasized or spread to the liver and the brain. So that would be the dehydration code plus 3 neoplasm codes. And so once again, I will, okay, I don't know what happened here. Um, give you an opportunity to code it and just hold tight because something happened with the screen. So hold on one second. Something happened with my mouse, I guess. Okay, one second. All right. I am back. I had to shut my computer down. All right. So, um, where we left off was you were about to code this scenario. I think I was about to ask if anyone had any questions about the scenario before you go off to code it. And hearing none, I will set the timer so you can get started. All right. Since you had that little break while I restarted my computer, I figure that you had started looking up some of this part. So I'm going to go ahead and reveal the codes. So, as I mentioned, per the guidelines, when the encounter is for management of dehydration due to malignancy, and only the dehydration is treated, the dehydration is sequenced first, and followed by a code for the malignancy. We had three neoplasms, one on the primary principal, or not even principal, it's not a principal. The Oh yeah, the table says primary malignancy. Primary malignancy was the breast cancer, which was the C50.411, and then the other two were secondary, and so those would be um, listed. Those would be listed in the last position. All right. Any questions on this case? And my mouse has done it again. I'm not really sure what's going on here. Okay, I hope I can get to the next scenario here. Okay, I don't see any questions, so I'm going to continue. So we have a patient with a known carcinoma of the pancreatic head, is admitted with a hemoglobin of 8.1. So let me just call out again. Knowing normal and abnormal laboratory values are important. And again, on the CCS exam, you are expected to query. There is no CDI to query for you. So the patient has been receiving docetaxel chemotherapy, and the physician documents that this new anemia is an adverse effect of the chemotherapy. The patient is treated with darbepoetin alpha and um, iron, and discharged with an improvement of the hemoglobin to 11.3. So there, of course, is a guideline for this. And again, today, I'll call out the guidelines, but my goal for the rest of the sessions is that when I call on you as individuals, you will know the guideline. So again, and I'm paraphrasing based on the words in the scenario. Management, when the admission is for management of anemia associated with the adverse effect of the administration of chemo, and the treatment is for the anemia. The anemia code goes first, followed by a code for the adverse effect. Which leads me to a guideline that just popped into my head. We haven't even gotten to this yet, but Chapter 19 of the ICD-10-CM guidelines gives us guidelines for um, coding adverse effects of a drug versus poisoning, and in what position the T code should be in. But this particular case, we're coding this anemia. That was an adverse effect of the chemo. And they only treated the anemia because they gave them the drugs and the iron, right? So that's that with that scenario. And anybody have any thoughts on this before I send you off to code? All right. So I will put the timer on again. All right. So here are the answers codes. So the first code, the D6481, this is chemotherapy that, or I'm sorry, anemia associated with the chemo. And then the second code, per guidelines, you assign a code for the adverse effect and the neoplasm. And so we have T45.1X5A. The A is for the initial encounter. And then that third code that we have there is the code for the actual neoplasm itself. Questions on this case? All right. Well, I will go ahead and set the timer for a 10-minute break. Uh-oh. What was the main term for the T code? Um, I would probably go with adverse effect as a main term. And let's go ahead and take that break. All right. So before the break, there was a question about what main term would you go to look up the T45.1X5A, and my response was adverse effect. And while we were on the break, I opened up my manual and went to adverse effect, and it sends you over to the table of drugs and chemicals. So, one thing I thought about on the break that I wanted to share with you all. So, I'm going to pull up a different screen. Is you may be saying to yourself, "Oh, I really need like some more practice." So I want to show you two resources that you might want to purchase for yourself. And I'm bringing these up because in this CCS exam prep, um, we unfortunately cannot go back to the basics of coding. We're coding, these few scenarios in diagnoses coding. Then we're going to transition to PCS coding, and then we're going to go right into those domains. There just isn't enough time. When I teach intro to coding, when I do teach it, I don't teach it that often anymore. I do straight 8 weeks of diagnosis coding, followed by straight 8 weeks of PCS coding, followed by straight 8 weeks of CPT coding, followed by straight 8 weeks of intermediate coding, bringing the systems together. So I know that if you have not had, coding in a while, you might be a little rusty. So this first resource is by the American Hospital Association. It's the ICD-10-CM, ICD-10 PCS Coding Handbook. I absolutely love this book. It is written in a little bit more advanced format, but I love that book. Another book, which is on the AHIMA website. So I'm going to go there now. So you go to the store and I don't go here that often. So I'm going to go maybe inpatient coding. And I'm looking for a book. So just in case you are like, what am I looking for over here? I'm looking for a book. So these all appear to be some type of webinar. So let me just back out of there and just go to, just look from here. So, oh, well, actually, here is the book I was mentioning, but this is the exercises book. So let me just see if I can find the book. It's called Basic, yeah, here it is right here. Basic ICD-10 CM and ICD-10 PCS coding. This one is a lot simpler from the perspective of understanding. It is gonna, take you to the guide, it's gonna introduce the guidelines. It's gonna it's gonna give you some practice with one line coding scenarios, kind of like what we did last Wednesday, but definitely a good resource if you see to yourself, if you say to yourself, you need a little review. That would be um a, a great resource. If I had to pick for myself, I definitely would say the AHA handbook. It just for me, I think it's a little bit more advanced, and since you guys are taking the CCS exam, definitely a way to go. All right, we're going to go on to our next scenario. The patient is admitted for chemotherapy. due to a primary hepatocellular carcinoma of the transplanted liver. The chemotherapy was administered with no complications and the patient was discharged. And once again, I'm going to call out guidelines. Um, Guidelines state if the reason for the admission is the chemotherapy, radiotherapy, immunotherapy, you would sequence first the Z code, whatever that Z code is, depending on if it's chemo, radio, immuno. And then you would list an additional code for the malignant neoplasm. Now, we got a little twist with this scenario because there is a situation. And the situation is the patient has hepatocellular carcinoma of a transplanted liver. So there is a guideline that speaks to neoplasm of a transplanted organ, and they refer to it as a transplant complication. And in that case, they actually give you two codes that you must also pick up. And so I will just call out for this scenario, you're going to need a total of 4 codes. The magic is in the guidelines. And so since you will probably want to go and re-review that guideline, I'm going to give you a little bit more time, but I want to serve notice that on Wednesday, you won't be able to. Right now, I have everybody on mute. You can only type in the chat. You won't be able to hide because I will be calling on you one at a time to call out a guideline based on a scenario. All right, so I'm going to give you an opportunity to find these 4 codes. So you're looking at, I would say, 2 guidelines that you need to reference. But you read these over the weekend, so I'm going to stop talking. All right. So I will display the codes. So, per guidelines, if the reason is for the therapy, the guidelines state something like chemotherapy, radiotherapy, immunotherapy, something like that. That code goes first. And then you would list a code for a malignant neoplasm associated with a transplanted organ. Um, and they call it a transplant complication. The guidelines even go as far to tell you that the code is from category T86. And then it also tells you to pick up C80.2. And then we need the code for the original cancer, which is the hepatocellular, hepatocellular cellular cancer. So those are the four codes. And tonight we only made it through 2 chapters. On Wednesday, we will speed it up considerably. I won't be doing all this commentary. And so, questions before I go over a couple of announcements that I have.